Hello, and welcome to the University of Washington, Washington Area Cardiometabolic Project ECHO Session 13. I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington Diabetes Institute. We're so excited for this ECHO program to continue. For every session, we do ask you to help us empower our patients living with cardiometabolic disease, and note that this is a safe space, as that there is zero tolerance for making people uncomfortable as we build this learning community together, which is really the heart of the ECHO model. So we're really excited for our lecture on patient selection for cardiometabolic medication, case-based examples of putting new guidelines into practice. And that's going to be Dr. Lakeisha George, a professor of medicine and nephrologist from Texas Tech University Health Science Center.
I'm Lekha George, and I am a professor at Texas Tech University and a nephrologist. And today I thank Dr. Hart for giving me this opportunity to talk about cardiometabolic. I would like to introduce also my colleague and my nephrology fellow, Dr. Natarajan, who will be doing the case in my presentation.
Thank you. Thank you so much for the opportunity, Dr. George, and thank you so much, Dr. Earhart, for the golden opportunity to present the case presentation part. Appreciate it. Looking forward.
Thank you so much. We're looking forward to it. But first, let's have Dr. Gail Nalandi Bland introduce herself, please.
Good afternoon. I'm Dr. Gail Nunley Bland. I'm in Washington, D.C. at Howard University. I'm an endocrinologist and director of the Diabetes Treatment Center at Howard University.
Thank you. And Dr. Lorena Wright, have you been able to join yet?
Yes, I'm here. I'm Dr. Lorena Wright. I am an adult endocrinologist at the Diabetes Institute at the University of Washington in Seattle.
Thank you so much. And finally, we have a great case that is going to be presented by Kendra Darnell, our nurse practitioner who's part of our native project in Spokane. Go ahead and introduce yourself.
Hi, I'm Kendra. I am a nurse practitioner here in Spokane at an urban Indian health center. So we're community health and Indian health services. Thank you for having me.
Great. And so, Dr. George, go ahead and take away our great lecture.
So the topic for today is patient selection for cardiometabolic medications. This is a new guideline-based practice that we are going to talk about. So today the objectives are understanding and managing cardio CKM health, to define it, to have a clear understanding of the CKM syndrome, which includes identifying the metabolic risk factors for CKM syndrome, for chronic kidney disease and cardiovascular disease. Then implementing this staging framework for risk stratification and prevention. And finally, identify prevention and management strategies as with the emerging therapies and interdisciplinary care. So as you all know, diabetes is a chronic, it's a systemic disease, and it causes metabolic disturbances as well as hemodynamic disturbances. In addition to that, it is an inflammatory process that happens. And when you have aggravating factors like high protein diet, obesity, or a genetic component like the ApoL1 genotype, then you end up developing a systemic syndrome, which now is defined as the cardiometabolic kidney syndrome. So as you see over here, the process of type 2 diabetes and the related complications happen over time. But unfortunately, most of the people do not recognize this early to prevent the primary or to do a primary prevention. And that's what you see over here. The impaired glucose tolerance happens from 4 to 7 years. And then by the time the patient has frank diabetes, both the microvascular as well as the macrovascular complications have set in. So what is CKM syndrome? It is basically a systemic disorder where the pathophysiological interactions associated with the metabolic risk factors leads to high increase in premature cardiovascular mortality and adverse kidney outcomes. So the American Heart Association had defined this syndrome and all came up with stages of this cardiometabolic health. And basically they staged it into 4. it starts with the stage 4 where there is no risk factors. And this is probably the ideal place where we got to start the primary prevention, followed by stage 1, which is basically telling us what the pathophysiology is. It is nothing but a dysfunctional adipose tissue. With increase in adiposity, it is realized that the phenotypic change has occurred. Prior, people had more of hypertension and hypercholesterolemia, leading to poor cardiovascular outcomes. But now they've realized that it is obesity and hyperglycemia that has changed the phenotype to cause premature cardiovascular disease. And therefore, the stage 1 is nothing but dysfunctional adipose tissue, which manifests as impaired glucose tolerance. So then followed by stage 2, where we manifest some of the metabolic syndrome changes like hypertriglyceridemia, hypertension, type 2 diabetes, and initial stages of chronic kidney disease. Then it goes on to forming the stage 3, which is nothing but a subclinical atherosclerotic cardiovascular disease and heart failure. Finally, the patient in most cases end up having what is nothing but heart failure, AFib, peripheral artery disease, and atherosclerotic disease. So what is the stage 1? As you see over here, this is the time that we all can identify these patients. When you see risk factors, that's when we have to really target our primary prevention. So when you see a patient in stage 1, when you got to see them pretty often, around keep a follow-up every 2 to 3 years. But if this patient is already in stage 2 and 3, then you've got to do an annual evaluation of this patient. And what are we looking at? We are looking at, in stage 2, the established risk factors like hypertriglyceridemia, management of hypertension, and/or chronic kidney disease. By stage 3, they have already manifested subclinical atherosclerosis, and we have to categorize them into a high-risk strategy, high-risk cases. So stage 4 is when, in most situations, like in my practice, I do not see them anytime in stage 1 to 3. And usually when I see these patients, they're already in stage 4, where they manifest features of atherosclerotic disease, amputations, heart failures, and advanced chronic kidney disease leading to dialysis. So now, what my goal here for you is to identify these stages and see how we can manage them. So I will give it to Dr. Natarajan to present the case.
Hi, doctor. Thank you so much for the opportunity. And this is a patient that we saw in the hospital. So this is Miss Jane Doe, a 44-year-old Hispanic woman with a past medical history of long-standing type 2 diabetes for the last 30 years, complicated by retinopathy, neuropathy, and nephropathy, hypertension, coronary artery disease, status post 8 stents, CKD stage 4, peripheral arterial disease, status post left BKA in 2022, hyperlipidemia, and a CVA with no residual deficits. She was transported to a hospital for NSTEMI, requiring higher level of cardiac care. She complained of upper extremity numbness, tingling, and weakness. The EKGs did not show any STT wave changes. Chest pain resolved on the same day, and troponin peaked at 130 and it trended down. And the CT was negative for hemorrhagic stroke. MRI was negative for ischemic stroke as well. And she regularly follows with a PCP and nephrologist. However, she hasn't seen an ophthalmologist or podiatrist in the last 2 years. And she's generally compliant with her medication, but she has problems controlling her blood glucose. And last A1C in October 2023 was 11.4%. And on this hospitalization, it was more than 10%. And the patient is separated, lives with her 3 children and her mother. And so that is, of course, your social support. And after amputation, she has been using wheelchair for ambulation, still drives, and she's still independent and reports that she's been able to do all her activities of daily life all by herself. However, her activities are limited and she doesn't exercise due to inconvenience and repeated events of falls. So the medications she uses is Clargin 30 units BID and insulin regular of 10 units TID, lisinopril 5 milligrams daily, metoprolol succinate 25 milligrams daily, aspirin 81 milligrams daily, and ticagrelor 90 milligrams daily, atorvastatin 40 milligrams daily, and Bumex 1 milligram BID. So these are the labs, pertinent labs, which include BMI, which is on the higher side, 30.3. The rest of the vitals were pretty much stable. And in the physical exam, nothing is significant except for here, she has some residual weakness. On the upper extremity, on the left upper extremity distal strength around 4/5, and on right lower extremity strength of 5/5. And the lab significant was with the creatinine of 3.1. The rest of the BMP looked pretty much benign, and even the lipid panel looked benign. The A1C is more than 10%, and the urine microalbumin creatinine ratio is around 3.8 grams. Urine protein creatinine ratio is around 6.7 grams. So on imaging, on a renal ultrasound in March, her right kidney is about 10.8 centimeters, and left kidney is 9.7 centimeters. There is increased echogenicity, suggestive of medical renal disease. And the echo revealed reduced ejection fraction of about 25 to 30%, with mid to apical akinesis and anterseptal hypokinesis. And recent screening with the depression was done in November, and the foot exam was done at the same time as well. It was normal. Retinal exam done in 2022 showed retinopathy. We don't know the staging. So the recent medication adjustments that we did during this hospitalization was her blood pressure was pretty much well controlled. And in regards to all the cardiac effects, we did put her on guideline-directed medical therapy for ischemic cardiomyopathy with ACE inhibitors, beta blockers was 6.2, home medication was carvedilol 6.25 milligram BID, but then we switched to metoprolol 25 milligram daily for reducing the frequency of administration. Other guideline-directed medical therapies include aspirin, ticagrelor, atorvastatin 40 milligrams daily, and also Bumex 1 milligram BID for volume overload due to heart failure with reduced ejection fraction and CKD. And she will benefit from switching from ACE inhibitors to an ACE and an RNA. And the MRAs can be helpful in regards to the proteinuria as well. And we were trying to maximize all her GDMT medications to the maximum tolerated dose. The blood pressure ranged from 118 to 130 systolics and diastolics 70 to 80, which is appropriate according to the KDIGO guideline recommendations for CKD. And for type 2 diabetes, she always had problems with maintaining the blood glucose levels. She's not on diabetic diet. She does not exercise. She has a sedentary lifestyle. She's never been referred to diabetes self-management education or a nutritionist. She would benefit some PT-OT evaluation for her residual stroke and also for not being able to do any exercises. She would have benefit for those things as well. And she was discharged on glargine 30 units BID, insulin regular 10 units TID pre-meal. So what would be an optimal management? I'm going to leave the stage to Dr. George to continue with this.
So the American Diabetes Association back in 2024 brought about a holistic approach that can be done to improve both the kidney as well as the cardiovascular outcomes. And therefore, what we see over here is it starts always with the lifestyle management. And this is what we have to do when we have to address the stage 0 of the CKM syndrome. Then we have included now the SGLT2 inhibitors, as well in addition to metformin as a first-line drug therapy. And if the hypoglycemia is not controlled with that, then we go on with GLP receptor agonists. And I know we have a lot of endocrinologists over here, so I'm not going to expose my ignorance there on that end. So I continue with my kidney and cardiovascular management. So in addition to that, we have to manage the hypertension with ACE inhibitors or calcium channel blockers, as well as manage the hyperlipidemia. So we need to do a holistic approach addressing all of these. So I have thrown the slide into this lecture to realize that yes, Jess, the American Heart Association recognized the CKM syndrome. But now MASLD has also come into the, it's a part of the systemic disorder. So what you notice over here is that when a patient has diabetes for about 2 or 3 years, 1 to 2 years, then we have to do the FIB scan to identify if the patient has a metabolic dysfunction associated steatotic liver disease and appropriately manage them. So It starts with the metabolic control, glucose control, weight management, and dietary modifications. And of course, the hemoglobin A1C is always targeted to less than 7%. And I would leave it to all the endocrinologists to hear, and I'm waiting to hear from them. Then I go on with, of course, where does SGLT2 inhibitors come into play? And basically what we see over here is, this is a normal kidney where, the glucose goes in, and so the sodium, all those, where with hyperglycemia, what happens is there is increase in the SGLT2 receptors, and therefore there is increased reabsorption of the glucose, and this causes, let's say, changes, alterations in the macula densa and those areas, causing efferent vasoconstriction, leading to increase in the glomerular pressure. So that's what you see over here. With SGLT2 inhibitors, what happens is basically most of these SGLT2 inhibitors act on the proximal convoluted tubules. And because these inhibitors, they are able to decrease the energy requirements in the proximal tubules, and therefore, in fact, it decreases the risk of AKI, and also simultaneously improves the, by causing glycosuria, it also blocks the pro-inflammatory substances and increases the free fatty oxidation, thereby improving the cardiac outcomes. So here, what we see over here is the cardiovascular risk management. And basically, this involves the hypertension control, lipid management, heart failure management, and the coronary artery disease management with aspirin for primary prevention. There was initially a four-pillared approach which was introduced by Dr. Backrus, but in management of the diabetic kidney disease, we also have included the statins, as well as, of course, in addition to the lifestyle modifications, which includes low-salt diet, no smoking, exercise, and weight loss. So when you are targeting the kidney outcomes, we have to use a multi-drug approach, which includes the two inhibitors as well as the RAS inhibitors, which act on the hemodynamic end. But in addition to the hemodynamic component, we also have the inflammatory component, and GLP receptor agonists have helped also, as well as the non-steroidal anti-inflammatory things like finerenone, helps in addressing the inflammatory component of the CKM syndrome. And added to that, we also have to look into using statins for the better lipid control. So what we see over here is basically that with SGLT2 inhibitors, we have improved kidney outcomes, as well as the outcomes to the first heart failure or cardiovascular death. There is definitely a decrease in the hazard ratio of around 0.51, with regards to the hospitalization for heart failure, it is around 0.75. So when we address any patient with either a reduced ejection fraction, as in my patient, we notice that we need to consider SGLT2 inhibitors, but make sure that you are looking at the hemodynamic stability of the patient, making sure that you initiate the SGLT2s before 20 ml per minute. And also genital hygiene is very important. Here, basically, this is nothing but a DAPA CKD study trial, which shows how this DAPA CKD basically shows that the SGLT2 inhibitors can not just be used for diabetic kidney disease, but it can also be used with other concomitant kidney diseases, which including glomerulonephritis and ischemic or hypertensive heart disease, kidney disease. So what is the standards of care of 2025 say? In adults with type 2 diabetes with high risk of atherosclerotic cardiovascular disease, they have found that to reduce cardiovascular events, you use GLP receptor agonists as well as SGLT2 inhibitors for better glycemic management and comprehensive cardiovascular risk reduction, irrespective of A1C. Then in adults with type 2 diabetes who have heart failure with a reduced or a preserved ejection fraction, and SGLT2 inhibitors is recommended for both glycemic management as well as prevention of heart failure hospitalizations. It also says that in adults like our patient with type 2 diabetes and symptomatic heart failure with a preserved ejection fraction, ours is a reduced ejection fraction, and obesity, a GLP-1 receptor agonist with demonstrated benefits of both glycemic management and reduction of heart failure related symptoms, irrespective of the A1C is recommended, and this is a grade A. In adults with type 2 diabetes with CKD, like my patient, and has an eGFR between 20 to 60 ml per minute, and an SGLT2 inhibitor or a GLP receptor agonist is demonstrated benefit for both glycemic management and slowing progression of the CKD and reduction of cardiovascular events. This is just a very busy slide, but basically we just have to know that SGLT2 inhibitors has to be initiated before 20 ml per minute, and it can be continued to dialysis and or transplant. So as I told you, lipid management is important. So you, in addition to lifestyle management, you started with the high intensity statins. And if the patient does not tolerate the statins, then go in with the PCSK9 inhibitors or other drugs. Now, here I just threw in this slide just to show you that the incidence of mortality as the population develop both albuminuria and impaired GFR, which is evident in a diabetic kidney disease, then the incidence of mortality goes higher. And therefore, cardiovascular management as well as kidney management go simultaneously hand in hand. So how do we do that? How do we recognize this? By albuminuria. So what do we need to do for that? Proteinuria reduction. Next is they recognize what stage they come in under. Usually what happens 90% of the time when patients are already in the clinic and have established a nephrology care, they are 90% of the population has not even realized that they had chronic kidney disease and they're already in their late stages of CKD. So that is very important for us to recognize. Here, I wanted to show you that, the nephrology world had a big drought of, medicines to be used for preventing worse kidney outcomes. And now with the SGLT2 inhibitors as well as GLP agonists, we have seen a remarkable improvement in the kidney outcomes in addition to the cardiovascular outcomes. So given this fact that with all this increased recognition, this has also been incorporated into the ADA guidelines for 2025. So here, as you all know, this is a heat map and basically which we use for the chronic kidney disease management. And what you see is as it turns the color to red, the patient needs to be seen, needs to be referred to a nephrologist, or we need to see them on a regular basis and manage them very aggressively. So how do we treat albuminuria? Optimize the blood glucose control, manage the blood pressure, then use of ACE inhibitors or ARBs, smoking cessation, weight loss, dietary modifications, and certain pharmacotherapeutics can be used. So this is basically a wonderful, back in 2000, about 25 years ago, Brenner et al. Had found that losartan was one of the first drugs that were shown to improve the kidney outcomes. And following that, now the SGLT2 inhibitors have shown that we are able to improve the kidney outcomes as we have shown in this slide. In addition to the SGLT2 inhibitors, then we have the mineralocorticoid antagonists, and now we have finerenone, which is non-steroidal mineralocorticoid antagonist. And basically, this acts on the inflammatory component, decreasing the fibrosis and addressing the albuminuria. So basically, what we see over here is the only drawback to using finerenone is, of course, the cost, as well as hyperkalemia can occur. So simultaneous use of SGLT2 inhibitors and finerenone can help in controlling the hyperkalemia. And of course, we have to do other additional modifications, like the resins can be used, like what is it, anti-hyperkalemic medication? Localma and all that can be used in addition to manage the hyperkalemia. Now, what we see over here in this slide is basically showing that GLP, how the mechanisms of action of the GLPs. And what we notice here is when you give GLP receptor agonists or dual agonists, we find that it addresses many factors of the cardiovascular disease, which includes decreased atherosclerosis, improves the high blood pressure, it causes improved cardiovascular outcomes. So this is basically Navneet et al. Has shown that the good thing about GLP agonists is, unlike the SGLT2s where we initiate them before 20 ml per minute, this can be given even in patients with very limited kidney function. And here in this trial, we saw the FLOW trial, it basically shows that the primary composite outcomes of kidney outcomes have been improved in addition to the cardiovascular outcomes. And they were able to stop the study much earlier because of the marked improvement that they have noticed with using GLP receptor agonists. So when we manage this CKM medications for the CKM syndrome, we got to address all these categories, which includes glucose lowering, BP lowering, lipid lowering, kidney protection, BMI lowering, as well as cardiovascular protection, in addition to lifestyle changes. So what we have to think is this is just one part of the management. But nothing can be impactful if we do not use a multidisciplinary approach. Because in most of the cases, okay, if I'm going to have a siloed approach and I do not introduce medications which might benefit from kidney outcomes just because of a low GFR, then it has to be a multidisciplinary involvement where there is endocrinologists like you, as well as nephrologists like us, who are able to address all this in a very holistic manner as far as the medications are concerned. So I leave it to Dr. Natarajan.
Thank you so much, Dr. George. And how are we going to implement all these learnings into our patient? So I'm going to go over on a recap of all the whole things that of the patient that we saw. So she's a 44-year-old Hispanic woman, long-standing type 2 diabetes for 30 years, complicated with retinopathy, neuropathy, nephropathy, hypertension, coronary artery disease, peripheral artery disease, status post-left PKA, and hyperlipidemia. Creatinine went up to 3.7 with a baseline of 2.7. And she has reduced ejection fraction of 25% and regularly follows with a PCP and nephrologist, but not ophthalmologist or podiatrist. Compliant with medication, but does not exercise, does not follow diabetic diet. A1C is more than 10, and social support she's separated, lives with her 3 children and mother, and she's wheelchair bound, transportation, and independent of for ADLs. So what are the parameters that we are supposed to gather when we see these patients in CKM stage 0 to 4? We can gather this information. And though it includes the weight, and the BMI is like 30.3, in regards to the age, duration of diabetes, she's 44 years, 30 years of diabetes, a lifestyle, she's a homemaker, and a sedentary lifestyle, and she takes predominantly Western diet, kidney function with an EG of 22 mL per minute, and a stage 4 CKD, and a family history of diabetes. She doesn't have any family history, and we have to look for medications that increase the insulin resistance. And complications of diabetes includes retinopathy, peripheral vascular disease, coronary artery disease, and nephropathy. Someone in the audience asked for the insurance status. So insurance is actually Medicaid, Amerigroup. So that's the class. And to bring this all together, she belongs to the category of CKM stage 4 with the renal involvement of the CKD stage 4 and then a low ejection fraction with a EF of 25% with peripheral vascular disease. And she had PKA done already before, and she already has CVA as well. So she had all the features of CKM stage 4. And let's try to use this thing in this for a small question, Vignet. So which pillars of therapy should be initiated to optimize care and reduce cardiovascular and kidney disease progression? Choice A is initiate an SGLT2 inhibitor for cardiovascular renal protection. Choice B is replace ACE inhibitor with sacubitril/valsartan for improved heart failure and CKD outcomes, and a thiazide diuretic for volume management and diuretic synergy. And choice D is both A and B. And you guys can give the answers on the comment section. So you like, I think most of them already got the answer. So it is choice D, which is include both SGLT2 inhibitor and an ACE and an RNA for this. And following up in the clinic after 4 weeks, the patient had shortness of breath, which has improved, still has some trace pedal edema. Potassium is 4.8. Potassium was even 4.5 during the hospitalization. Creatinine is 1.7. EGFR improved a little bit to 31. And urine albumin creatinine ratio is 420. What's the next preferred step in the management? A is add a thiazide diuretic. B is increase furosemide. C is dotfinerone, and D is A and B. So the right answer would be to do dotfinerone, which would improve cardiovascular outcomes and also kidney outcomes in general. So that's what we have to do. Dotfinerone, if the potassium goes up, there are times when we can do, that's when Dr. George mentioned about adding Localma so that the patient has the best medication to go with and be on Localma as well, so that they can continue with this medication. And that shouldn't be a deterrent to not start on finerenone, and even that applies to ACE and an RNA as well. I leave the next segment to Dr. George to continue. Thank you, Dr. George.
So one thing what they noticed was with the CKM syndrome is what we need to really address is not the management of the CKM, but to identify why are these patients coming late in the game. And it is because of the social determinants of health, which includes the social demographic factors, the food insecurity, the housing instability, and the financial strain, which I think is a very typical patient that we all encounter. So how are we going to address these gaps of care? And that for this is where people like us come in this platform, the Project Echo, the wonderful platform, and we can address this together collectively. Because there are things that I am very good at writing that my prescription, but I still don't know, okay, how am I going to get this patient to get this medication? So this is where I like your opinion and your recommendations. So let's just target this patient collectively together to make sure that she have a better outcome. And that is what we are all looking for. So when we are doing this, we approach this as a value-based care and a volume-based care. And so when you do a value-based care, basically you are, when you identify 2 or 3 more conditions like CKD, diabetes, then you have to do an interdisciplinary team approach. Volume-based care is when you notice that, when the specialists have a 4 to 5 or 6 months, referral time, then you have to make sure that if you're able to address the earlier stages, then it would be much easier that they can get, the late folks can get attention. And that is a better way to address it. And telemedicine or Project Echo would be a good way to look at that. So, I want to have a patient-centered implementation focus, we first have to address the social determinants of health and then involve the pharmacist to assess to pharmacotherapies. Then, of course, we need interdisciplinary care, the dietitians, the social workers, and then the endocrinologist for better hypoglycemic control. And finally, the nephrologist and the cardiologist come into play. Thank you. Thank you again.
Thank you so much, Dr. George. That was a great putting it all together case. And what I really loved is that you highlighted this person was definitely throw the kitchen sink at it. So the 4 pillars, but the problem is wouldn't it have been great if we would have gotten her before she developed any of her complications, right? And so the question you had asked me and asked the endocrinologist in the group is, what would we do for her glycemic management? Because maybe if we would have gotten her access to care and better glycemic management earlier, and as well as additional blood pressure control and management, maybe she wouldn't be stage 4 kidney disease, having had an amputation, neuropathy and retinopathy and being trending towards dialysis, definitely. So, we were having like a little chat because I'm hoping at this point, all our primary care providers will notice things and be able to select the right diabetes management. So one thing that was pointed out is that this person has, a GFR of less than 25, but she's on a very high dose of background insulin. Her basal insulin is close to 1 unit per kilogram at 30 units twice a day since she's only 70 kilograms. So as we've talked about before, the American Diabetes Association recommends no more than 0.05 units per kilogram because of the risk for hypoglycemia. And so it was suggested that potentially her background insulin dose might be too high. And this also led to us to discuss how often is she taking the insulin? Is she having low blood sugars? And so someone pointed out that we should potentially, she meets the criteria for continuous glucose monitoring. So we need to gather more information to see what's happening. And then we need to ask her how often she's actually taking the insulin so we know what her cumulative insulin dose is. As well as one of the 4 pillars, GLP-1, because of the high efficacy of A1C lowering, was mentioned as a tool for this patient. And then the final question is if we add this high efficacy medication, what do we do for her insulin dose? And someone suggested to just sort of reset it and just go back to basal insulin for ease of use for the patient with a daily or weekly GLP-1 based on the insurance. And I agree that might be a great option. I would probably put her at no more than 0.3 to 0.25 units per kilogram, so somewhere between 25 and 35 units of basal, and start that GLP-1, whether it be liraglutide, semaglutide, deglutide, and then go from there. Alternatively, if we really teased out that she was taking her insulin doses or just skipping it when she was normal, I might, and we really sense the need for prandial insulin, she's someone I might use 70-30 or a preferentially Humalog 50-50 insulin and sort of start maybe at 20 units twice a day, breakfast and dinner as a starting spot, and then maximize the GLP-1. And I'm going to throw this over to Dr. Lorena Wright if she had any other ideas before we go on to our case.
Yeah, no, I think I agree, Nicole, with your assessment, your recommendations. Yeah, like sometimes the use of insulin, it's, we really kind of have to ask a lot of questions to figure out exactly what they are doing with their insulin. And that I think this group of people, I think they, as you say, they feel comfortable, asking these questions. But yeah, great case.
I think the final thing is this is the difference between the endocrinologist and nephrologist. I would say, manage the hyperglycemia first with the GLP-1 and insulin as an adjunct if needed. Then as the glycemic condition improves, add the sodium glucose cotransporter inhibitor for outside of glycemic control. And then if the pill burden isn't too much for the patient, add finerenone, again, to support the kidney health. And of course, this is always in the maximal setting of ACE and statin use. So on that final thought, I will ask us to start our great case presentation.
Okay, so I have a 51-year-old female who is Native American. I'm presenting this case because of the challenge that she actually has type 1 diabetes, but she has obesity that has been requiring higher doses of insulin. She's been asking to use a GLP-1 to help with both weight and improve insulin resistance metabolism, and even throwing some fatty liver disease in that as well. So she was diagnosed in 1997, but there was some confusion on whether or not it was actually type 1. And so in 2022, we had some labs that did show positive GAD 65 low C-peptide. She had been on insulin at that point. We also have hypertension. She is on losartan, hyperlipidemia. She's now back onto a statin. We have metabolic dysfunction associated liver disease. BMI last was 38.1, which has been going up over the last few years. Glaucoma, no evidence of diabetic retinopathy, chronic polycythemia, and then has had menorrhagia, which has been treated with Depo, although we've been trying to find other approaches. She's been really wanting to stay on that. So current medications, she's pretty high dose of her, and kind of adopting someone who's already kind of had diabetes for a long time and they've created their own regimen. But Lantus, we're at 60 units being Humalog. It ends up being 50 to 60, but it can be quite a range. And it's been very, I wouldn't say willy-nilly, but she has this kind of her own way of deciding how much insulin prandial to give. She does have the depot every 13 weeks, eye drops, and losartan. And the statin has been started since the last update here. She has previously had intolerance to lisinopril, but seems to be doing fine on losartan. And then family history, she actually, and I have the unique opportunity to see multiple family members. Other sisters have type 2 diabetes. We've looked at labs for them, do not have type 1 markers, all very insulin resistance, requiring pretty high doses of insulin, mother with type 2 diabetes. And then patient has rheumatoid arthritis, but that seems to be under good control. No known family history of heart disease. So she works in a medical clinic. She's currently single, but has a lot of family living with her. No tobacco use, no current use, and no history of heavy alcohol use. You can see her vitals. Those have gotten a little bit better. I was trying to look at previous ones, but now that she's taking losartan consistently, we're starting to get systolics in the 130s. And her last A1C at 7, and that's actually kind of where she lives most of the time. So hasn't had any above 7 in quite a few years. So stays in range. We do see a little bit higher LDL or the LDL, but again, she has been and started on a statin since these labs were done, and then elevated triglycerides. She's very good at getting her urine creatinine done, and we haven't had any evidence of proteinuria. We did have an ultrasound that did show hepatic steatosis because of the depot use, and not knowing her period status and menopausal status, we did get a normal DEXA. Her foot exams have always been normal. Again, I've seen some of the ophthalmology reports and there hasn't been any retinopathy, just the glaucoma, and states regular dental. So we're in an interesting, works in a medical facility, and I think there's some resistance to getting some of the service, and living with diabetes for so long, there has been resistance like, well, I've had this for such a long time. I don't really need to see a dietitian. I don't need to do diabetic classes. So has been encouraged, but has declined at this point. Doesn't have a lot of social barriers at this time, has good insurance and access to medicine. Well, those are the social. So the barriers that we've been finding is hesitant to start new treatment approaches, especially medicine. So even just like the statin, trying to re-encourage, has not wanted to do a CGM. Struggles with just being consistent, both with nutrition and exercise. Will be on kind of a really good regimen and then really go backwards. And so have encouraged on-site dietitian and referrals out. And she, again, kind of feels like I feel like I should know what to do. She found a lot of benefit both for her diabetes and her weight doing a keto style diet, but couldn't maintain that. Again, many people living in the home and making meals, and found that was just really prohibitive. So it tends to kind of vacillate between very strict to then almost kind of no change, or no rules kind of eating. So the big question she's been asking is, can I do a GLP-1 with this diabetes?
Thank you for that great case. Does anyone have any clarifying questions? Gail, I think you had a clarifying question as well.
Yes, I just wanted to know, has she ever been on a CGM, or does she have any opposition to using a CGM?
She does. We actually have samples we've offered, and very much does not want to, but it hasn't been able to really express why. I think she's uncomfortable with the idea and has not had a desire.
Thank you.
Gail, go ahead and take away our case discussion.
All right, well, this is a very interesting case as we are improving our care with our type 1 diabetes and they're living longer. We're seeing obesity and this whole cardiometabolic syndrome occurring in them and not knowing really what to do with them. So this is a great case. I enjoyed looking at it. I have no disclosures, and I will be discussing off-label medications for use in type 1 diabetes. Let me just recap the case. We have a 51-year-old woman with a history of type 1 diabetes for 28 years. She has hypertension, hyperlipidemia, metabolic dysfunction, associated liver disease, obesity, open-angle glaucoma, polycythemia, and menorrhagia. Current medications include Lantus, 60 units BID, Humalog, 50 to 60 units before each meal, medroxyprogesterone acetate, 150 milligrams, give 13 weeks, Combigan, 1 drop twice daily, losartan, 25 milligrams. And I just heard that she is on a statin right now. Her height, 66 inches, weight is 236, BMI is 38.1, blood pressure has improved since she is, I'm taking, I guess, her losartan, and her heart rate is 91. Significant labs include A1C of 7%, her creatinine of 0.56. I didn't see an EGFR, but that may be something that we would need to look at. Her LDL 93, HDL is a little low for a woman her age, and her triglycerides are elevated at 247. The labs that were done, the C-peptide, I'm assuming was less than 0.1 and it's in nanograms per ml. She had a positive GAD antibody. Her IA2 antibody was negative, and she had a positive insulin autoantibody, but she was on insulin at the time when these were done. Her abdominal ultrasound showed enlarged and echogenic liver consistent with hepatic steatosis, and she had a normal DEXA in 2019. Okay, so my question is, does she have type 1 diabetes? And I'm opening this up to Lorena. And what would you have as her A1C goal?
Yeah, well, I mean, we have the benefit that we already know the result of the GAD antibodies, but if I didn't have that, right, like I would maybe think that this might be type 2, really, because it's a very high risk ethnic group and obesity and the family history. However, because she also has rheumatoid arthritis, like then that's an autoimmune disease. So then that's why I think I really love that when we discuss the cases here in ECHO, we always stop and ask what type of diabetes the patient has, because at times, right, like this patient, we might think that it's type 2, but that it actually is type 1. So yeah, and then the goal for the A1C. So the limiting factor for a normal hemoglobin A1C is hypoglycemia, and so that A1C of 7 is pretty good. However, in someone with type 1 diabetes, right, like I really prefer to well, everybody does, right? Like to have the data of CGM, because we don't know, how much hypoglycemia she's having. So I probably wouldn't go lower than 7 without a CGM. If she had a CGM, then, like I'll feel more comfortable that I'm not missing hypoglycemia. But yeah, no, people with type 1 diabetes, even if they do, have insulin resistance, because they are not producing any insulin, C-peptide is low, undetectable, they are at higher risk of hypoglycemia.
Okay, I agree with your assessment. And I was just going to go over what the American Diabetes Association. Sometimes it's difficult to assess what type of diabetes someone has. I mean, looking at her, I agree, you would probably think she had type 2 diabetes. But many times we have to really think about, particularly those who require insulin, not really responding to oral agents. We need to determine if they have type 1 diabetes. And she does have a positive GAD antibody. So right here, we can almost stop and say that she has type 1 diabetes. But in some cases, 5 to 10% of individuals may have negative GAD antibodies, and then you would have to go down the paradigm in terms of whether she's young at the time when she was diagnosed, when she was less than 35, does she have monogenic diabetes, and looking at the C-peptide levels, if it's elevated, then that may go along with that. If it is low, and generally with a C-peptide of less than 1.8 nanograms per ml, that goes along more with type 1 diabetes. Or if she has positive C-peptide greater than 1.8 nanograms per ml, then probably she is not a type 1 with negative antibodies. So this is helpful in terms of trying to decide which type of diabetes the patient may have and the treatment that we would want to implement with this person. And then the goal, as you mentioned, probably 7% is good for her, being that we do not know if she's having hypoglycemia. She is on a large amount of insulin and maybe having some hypoglycemic unawareness. She's had longstanding diabetes. So it really would be beneficial if she had a continuous glucose monitor. But if we look at this paradigm here that older adults with complex medical problems, then maybe we shouldn't try to reach that less than 7%. If they've had long diabetes duration, high hypoglycemic risk, polypharmacy, pharmacotherapy, established cardiovascular complications, and severe life-threatening comorbidities, this is someone that I would not try to really have tight control of less than 7% or even less than 6.5%. So this brings us to the clinical question. This patient has obesity, is on very high doses of insulin, maybe due to resistance, wants to use the GLP-1 to improve her weight and her insulin resistance. And so my question is to Nicole, what is her risk, her cardiovascular risk, and what are the patient's goals?
Great question, because I think we are talking about the whole body health. And I think this is a question we have to teach and educate our patients to ask so that we can partner together, because we want to work on things for whole body health. And so the third question that I've always been asking myself when I'm talking with my patients is, what is their cardiometabolic risk, whether it's type 1 diabetes, type 2 diabetes. And like I said, I add that to what is the patient's goal, because sometimes they need to be educated and have knowledge to empower them to know the right question to ask. And so in this patient's case, similar to some of our other cases, we did a cardiovascular risk calculator. And what you found by her characteristics is that she was at borderline risk for her 10-year, but her lifetime risk was very high, over 20%. And I think this is what we teach about type 1 diabetes, is that some of the standard calculators may underestimate their risk, especially in the 10-year point, because they've had their diabetes for longer duration. And then metabolically, we heard in the last lecture how even elevated BMIs earlier can signal that they may be at increased risk for things like heart failure as they age. And so, this person cardiometabolically is at very high risk. And we just want to make sure that we make her aware and are educated about it so we can support her whole body health. And that then will lead to, part of the reason why we may ask for diabetes management outside of insulin in our type 1 diabetes patients. Thank you, Gail.
Great discussion. Okay, so we're realizing that obesity, the prevalence of obesity and type 1 diabetes is similar to the general population, like 28%, and they are at increased risk for developing adipose-related cardiovascular disease. Up to 40% of them have hypertension, up to 40% have metabolic syndrome, 12% have metabolic dysfunction-associated liver disease, 16% chronic kidney disease, and up to 46% have obstructive sleep apnea. And just looking at what are the pathophysiology of this, well, we know that we have to give insulin for type 1 diabetes, but these insulin doses actually is lipogenic. They have an increased risk for weight gain, and then this can accelerate pancreatic beta cell destruction. It can lead to immune dysregulation because of the increased weight, which then leads to chronic inflammation. And the insulin levels that we often have to prescribe, it disrupts the growth hormone IGF-1 axis. Depressing IGF-1, growth hormone levels go up. But because the insulin is on board, the signaling pathway is disrupted. And then also the enteroendocrine signaling is also disrupted, suppresses GLP-1. And so that we have this mechanism in terms of satiety and eating can be a problem. And one of the things is fear of hypoglycemia. Many people with type 1 diabetes are often worried about, particularly at night. They may allow for their blood sugars to go up, or they may overtreat their hypoglycemia, so we have to address that. And then intensive glucose control, as we're trying to ratchet down the A1Cs and we're giving more and more insulin, this can contribute to the weight gain due to the high insulin dose. So the obesity or the adipose is probably one of the precipitating factors that we're seeing this whole cardiometabolic syndrome that we're seeing. Increased hypertension, chronic kidney disease, metabolic associated steatosis, liver disease, increased metabolic syndrome, cardiovascular disease, and obstructive sleep apnea. So what do we do in terms of treatment for type 1 diabetes? I think we always start with lifestyle. Medical nutrition therapy is key in terms of limiting the caloric intake so that we do not have to give as much insulin, improving our exercise and physical activity, and behavioral interventions. Now, the medical nutrition therapy for type 1 diabetes, before the discovery of insulin and use of insulin, actually the treatment was a low carbohydrate diet to manage diabetes. The American Diabetes Association defines a low carb diet as 60 to 130 grams per day, which is 26 to 45% of the daily caloric intake. Now, in her case, she was on a ketogenic diet, which is a very low carbohydrate diet, where you're only consuming 20 to 50 grams of carbohydrate a day, which is less than 26% of a 2,000 calorie a day diet. But one of the disadvantages of a ketogenic diet, it puts type 1 diabetes at risk for ketoacidosis. You begin to start breaking down fat. And if they're using this kind of diet, they really have to monitor their ketones or their urine ketones because they may go into ketoacidosis. The other disadvantage to a very low carbohydrate diet is that you can see an increase in your total and LDL cholesterol. So this is one of the disadvantages of using a very low ketogenic diet in type 1 diabetes. Another type of medical nutrition therapy is intermittent fasting. And you can not consume meals anywhere from 12 to 16 hours. And then it's a little tricky in terms of managing the insulin when they are not consuming any foods. So that puts them at an increased risk for hypoglycemia, particularly if they're not using a continuous glucose monitor. The physical activity, exercise and physical activity in type 1 diabetes, generally it's the same recommendation that we give for people who do not have a diabetes or who have type 2 diabetes or pre-diabetes, is to try to get at least 150 minutes. Aerobic exercise tend to decrease the blood glucose, and anaerobic exercise may increase but provides a more stable glucose. But again, it's important to use a continuous glucose monitor while exercising. And with the automated insulin delivery devices that we have, this may mitigate some of the exercise dysglycemia because of the reduction in terms of the amount of insulin that either you can program it to reduce the insulin, and also the devices will stop insulin delivery if your blood glucose drops too low. And then behavioral interventions, and really inquiring about any fears for hypoglycemia. And up to 60% of individuals with type 1 diabetes have this fear of hypoglycemia, which is associated with overeating. They don't want to exercise because they're afraid their blood glucose will drop. This can lead to depression and anxiety, reduced quality of life, and decreased sleep quality, being afraid of becoming hypoglycemic during the night. And generally, this is in younger women that you should screen for eating disorders, because some young women will intentionally omit insulin so that they do not gain weight. And up to 40% of type 1 diabetes women, or actually men too, can use insulin as a way of controlling their weight. But then that leads to the hyperglycemia and the complications that are associated with poorly controlled diabetes. And you should consider to refer for a psychological evaluation if you think there is disordered eating patterns or hypoglycemic fear of hypoglycemia. And it's important to offer diabetes self-management education if needed. So, what are some of the management medications that you need to actually screen for that maybe you can change that may promote weight gain? Now, we know that multiple insulin injections, as we're trying to control the diabetes, can promote weight gain. Insulin pump users can promote weight gain as well. And so, in this particular case, this individual is on nearly 200 units of insulin a day, and that's quite a bit of insulin for her, and that may also contribute to her weight gain. So I'm looking at that and looking at what her numbers look like. I'm not sure if she's checking her blood glucose on a regular basis or whatever, and whether she is having hypoglycemia is something that I think needs to be addressed and reviewed. But also some of the other antidepressant or weight promoting medications, such as antidepressants like SSRIs, are antipsychotics, such as haloperidol, are anticonvulsants, such as gabapentin, carbamazine, corticosteroids, whether it's injectable, inhaled, or orally, antihypertensive medications such as clonidine and beta blockers. And she's on the medroxyprogesterone acetate, which has been associated with weight gain, as well as progestin IUDs or implants can be associated with weight gain. So getting to the pharmacologic interventions, we really do not have any FDA approved pharmacologic interventions except for pramlintide, which is the only FDA approved adjunct therapy for type 1 diabetes. And because you have to give it 3 times a day as an injection, there has been very little weight loss associated with it. Only 0.5% of your weight loss is associated with it, but it is useful for reducing the amount of insulin that is administered. I was going to ask Nicole in terms of her use of any of these agents, Formin, and then also some of our other agents, our anti-suppressant agents like phentermine, those kinds of things. So I'm going to let you give your insight on using some of these other ones.
Thank you. And of course, these are all off label because it's type 1 diabetes. But one common medication that does have some literature on it that I wanted to highlight that we often try to use to improve insulin resistance in type 1 diabetes is metformin. And there was a removal study, which was a double-blinded, randomized, placebo-controlled study. And you'd think, oh, you'll get some weight loss, you'll decrease insulin resistance. And I think that's why we often try metformin on our patients. However, as you see with this study, what they found was that there was very little change in insulin dosing and there was very little weight loss associated with it. But what they found was that when they looked at markers for cardiovascular risk mitigation, there was some improvement in that. So it is a medication that I'll offer to my patients. And what I find is, and I look at their total daily dose before and after, I look at their weight before and after, and then we make a decision after 3 to 6 months if we should continue the medication. If we feel like there's been some benefit, we continue it. If we really see no difference, we stop it. And so I'm curious, Gail, if you have any other thoughts about what you do with metformin.
I have tried metformin in patients with type 1 diabetes, and I really haven't seen much in terms of weight loss with it. And I guess, you may get some improvement in, some of the cardiovascular aspects of it, but I have not seen a lot of success with it.
Yep. And just for the sake of time, I will say that because a lot of the time we cannot get GLP-1 receptor agonists approved in type 1s, I have used phentermine products in my type 1s as long as they're not high cardiovascular risk or have already had a cardiovascular event. And I do get the same about 10% weight loss, a decrease in insulin dose with it. And so I would consider using a product like phentermine in this patient if a GLP-1 receptor agonist is not available. And I'll let you go back to your discussion about other medical interventions.
Thank you. Also, I have put up here surgical interventions, and the vertical sleeve gastrectomy may be a better option for type 1 diabetes because it decreases ghrelin and increases postprandial GLP-1 and PYY levels. But you would have to make sure you reduce the amount of insulin that they are on after they've had the surgery. I've had some experience with using surgical interventions with my type 1 diabetics. And she did lose a significant amount of weight, and we had to significantly reduce her insulin dose down. But again, this is, again, probably a little off label in terms of what we're doing with that. The Roux-en-Y gastric bypass is a malabsorptive surgical event, which may be somewhat challenging with someone with type 1 diabetes and the biliopancreatic diversion is another mellisorptive intervention. But they do work in terms of weight loss in these individuals. And I guess there is some studies that say that there is some improvement in their metabolic control. Okay, so this brings us to the question of the case, the GLP-1, and we've heard that it has multiple benefits in terms of reducing body weight, improving plasma lipids, decreasing your glucagon. Now, insulin, because they don't have any insulin, that would not be a benefit in this particular case, but the suppression of glucagon may be a benefit for type 1 diabetes, decreasing inflammation, decreasing insulin resistance, improving endothelial dysfunction, stiffness, and sodium excretion in the kidneys, and improving myocardial contractility and ischemic preconditioning, and suppressing the appetite and increasing satiety. So it is one of these great drugs in terms of weight reduction as well as improving cardiometabolic processes. And I was going to ask Lorena, have you ever used any of these GLPs in your patients with type 1 diabetes?
Yes, yes, I have used it also, like metformin and the other medications, but I use GLP-1s in my patients with type 1 diabetes and obesity with quite a bit of education, close follow-ups and education on the prevention of DKA and hypoglycemia, and then adjusting insulin appropriately. But yeah, I think a lot of times the barrier is the insurance, but yeah, I have quite a bit.
And I was wondering if you have some of these other secondary causes, say, you have obstructive sleep apnea, and I think this hepatitis has been approved for that. You put that on, would that work? I don't know, but these are things
Yes,
that
when I write for a GLP-1, when I prescribe, I put all of the complications that have secondary to obesity. So then with the hopes that will increase, the chances of getting this approved.
Okay, great. So we do have studies here that have used the GLP-1 receptor agonist. And the first one here was actually published February 2025 in the Mayo Clinic Proceedings. And this objective was to determine the effect of tirzepatide, body weight in adults with type 1 diabetes and overweight or obesity. This was a retrospective study. A total of 51 patients were studied, and what they did was they followed these patients up to 18 months, and they looked at their percent weight loss. And after 18 months, they had lost 13.1% of their weight, and there was a 31.6% reduction in the amount of insulin they needed. They saw improvement in their cardiometabolic function. There was no increase in hypoglycemia, of course, with the adjustment of their insulin. And the most common side effect in this particular study was the nausea that comes with using these particular agents. The other study was on the efficacy and safety of tirzepatide in overweight and obese adult patients with type 1 diabetes. Again, this was a retrospective study. 62 patients were studied. The A1C dropped by 0.767% at 1 year, and their average weight loss was 18.5%. Now, the caveat for this is studies to date on the use of these medications have been retrospective and should be interpreted with caution. Clinical trials are currently investigating the effectiveness and safety of liraglutide, semaglutide, and tirzepatide in people with type 1 DM and obesity prospectively. So I think we'll be looking forward to the results of this, and hopefully we can get FDA approval to use these particular medications. The SGLT2 inhibitors have not been approved for type 1 diabetes. So that is because of the increased risk of euglycemic DKA. There's a threefold increase. So we haven't gotten the FDA approval for that. And so that is one of the other cardiometabolic medications that could be beneficial, but right now we have no FDA indication for the use of that particular medication. This was published in the Diabetes Science and Technology in January of this year. And this was a consensus report for the use of glucagon-like peptide receptor agonist as adjunctive treatment in individuals with type 1 diabetes using automated insulin delivery system. So they convened a panel of experts in the use of these automated insulin delivery, and they all looked at the data to see how effective using these agents with someone who is on a continuous glucose monitor and using an automated insulin delivery device. And now the diabetes standards of care really recommend all type 1 patients have a continuous glucose monitor and to use automated insulin delivery devices to manage their diabetes. And so with this, they came to the conclusion that the GLP-1 receptor agonist would provide effective adjunct therapy and it would improve glycemic and metabolic outcomes without the increased risk of severe hypoglycemia or diabetic ketoacidosis. So there is data, or at least interest in using this particular medication in type 1 diabetes. Now, if you do use it, then you need to realize that you're going to have to reduce the amount of insulin. And this was a recommended guide that was published in a diabetes research clinical practice, that if their A1C is less than 7%, when you put them on these agents, you should decrease their insulin dose by 20 to 25%. If it's greater than 7%, then to reduce their insulin dose by 10 to 15%. And if they're having frequent hypoglycemia on their current dose, then reduce it by 25 to 30%. You need to monitor them every 1 to 2 weeks after insulin dose adjustment to prevent the hypoglycemia, hyperglycemia, or DKA. So my recommendations, I really strongly recommend a CGM for this patient. I don't know if you can convince her, but I feel as though this way may give her more insight to her diet, what may be contributing to hyperglycemia, or if she has unrecognized hypoglycemia. I mean, she is on a large dose of insulin, so I'm hoping that she would reconsider using the CGM and explore any fears for hypoglycemia and the need to overtreat, and inquire if she would be interested in a low carb or Mediterranean diet or plant-based diet to help lower her insulin dose and weight. I really would have consult with GN regarding the medroxyprogesterone acetate if there is any other medication that can control her menorrhagia. This also has been associated with the use of hypertriglyceridemia, and she already has that. So that would be a medication that I would see if that could be changed. And you could consider or talk to her about considering prescribing an automated insulin delivery system with CGM, and maybe consider using the GLP-1s or the GIP, dual GLP-1 receptor agonist, even though it's off-label, or even if she wanted to continue on multiple dosing MDIs with these agents, with the GLP-1s or GIP, GLP-1 dual agonist, that would be something. But I truly think or strongly believe she should be on a CGM.
Thank you, Gail, for that great summary. I think this is the way that we could maybe start a partnership saying, if we're going to add this medication, potentially, especially during the medication changes and escalation, gathering more information through a CGM. And so asking if she would wear it a few, 3 days out of the 14 out of the week, or if there's some way that we could support her so she'd be comfortable wearing, especially during the escalation phase. And then, the final thing I think before we end the session is Dr. Wright made this great comment that a lot of time it's not about what you and the patient decide, it's what the insurance covers. And so a limitation may potentially be for GLP-1 or GIP, GLP use, unless they have an alternative indication, like have already had a cardiac event, or potentially now sleep apnea for tirzepatide. However, we always are created for our patients, right? And what I'll say is I believe there's enough evidence, of using GLP-1, GIPs with our type 1 diabetes. And so if we have access to them, we should. Specific to our native healthcare formulary, we do know that semaglutide or Ozempic is now on their formulary, and so you may be able to write it as a formulary medication and utilize it off-label in your type 1. And so the final thought is partner with the patient to support their needs, be creative, but set small goals with them, and then keep advocating for the patient for all those medications so we can best take care of their whole body health. So on that note, I will say this ends session 13 of the Cardiometabolic Echo. Thank you.